Good morning. Today I will present to you the second part of the congenital heart disease, the second lecture. In the first lecture we discussed the cyanotic congenital heart disease, the defects associated with left to right shunt, including ASD, VSD and PDA. Today we will continue to discuss the second part or second group of the congenital heart disease that present with the right to left shunt, cyanotic congenital heart disease. Cyanotic congenital heart disease, the most common and frequently seen, this is the Tetralogy of Value. Tetralogy of Value account for 10% of all congenital heart disease and the most common cyanotic congenital heart disease in children. Tetralogy means 4 components. It's composed from overriding of the aorta. That means the aorta override the interventricular septum. The second part is the large VSD, malalignment VSD. The third part is the RVOT obstruction. That means right ventricular outflow tract obstruction. The obstruction could be subvalvular below the pulmonary valve, and could be valvular, that means pulmonary stenosis, and sometimes supravalvular stenosis involving the pulmonary arteries, peripheral pulmonary arteries. So RVOT obstruction. The third or fourth part of the tetralogy is the right ventricular hypertrophy. So tetralogy of Value composed from 4 abnormalities: the overriding of aorta, large VSD, RVOT obstruction, and right ventricular hypertrophy. So from this diagram and from these components of TOV, you can imagine the pathophysiology and hemodynamic changes that occur in tetralogy of Value. The blood return, venous blood return from the SVC and IVC enter the right atrium through the tricus valve, pass into the right ventricle. In the presence of large VSD and severe RVOT obstruction, right ventricular outflow obstruction, so the preference of a flow is toward the VSD. Okay, so some of the blood goes to the pulmonary artery through the RVOT, stenosed RVOT, and the other parts of blood pass through the VSD into the aorta. So causing mixing in the aorta, there is oxygenated blood mixed with deoxygenated blood from the RV. This is the source of the cyanosis. Okay, so from here, the degree of cyanosis and the degree of right to left shunt is dependent on the severity of right ventricular outflow obstruction. Depend on the severity of pulmonary stenosis. So, as pulmonary stenosis going more severe, so that means more blood shifted to the left side, and the patient presented with more cyanosis. Okay, in some cases with mild RVOT obstruction or less severe RVOT obstruction, the patient usually presented later on, and usually cyanosis just mild cyanosis and sometimes no cyanosis at all. It's called pink TOV. With time, pink TOV or acyanotic TOV develop progressing severity of the RVOT obstruction, increased severity of PS, resulting on classic TOV within 1 to 2, sometimes 3 years of age. So, presentation: most infants with TOV are symptomatic, the classic TOV, with cyanosis, clumping, dyspnea on exertion, squatting, this is characteristic for TOV, or hypercyanotic spells. hypoxic spells or Tetralogy spells. Right ventricular heave and systolic throb at the lower sternal border are usually present because of RVH. A loud and single S2 and loud systolic ejection murmur at the middle and upper left sternal border are present. The source of murmur is not the VSD. The source of murmur is the RVOT obstruction or pulmonary stenosis. Why? If you turn back to this diagram, the VSD usually large VSD, so the gradient between LV and RV is minimum. So there is no significant pressure gradient differ between the RV and LV. Okay, so murmur is soft or absent. Sorry. So the murmur you hear in patient with TOF attributed to the pulmonary stenosis or right ventricular outflow tract obstruction. Hypoxic spells may develop in infants, brain abscess, cerebrovascular accident, thromboembolic, and bacterial endocarditis, infective endocarditis are rare complications. Polycythemia is common, but relative iron deficiency state, hypochromic with normal hematocrit may be present. We call relative iron deficiency anemia in patients with polycythemia and cyanotic congenital heart disease. Also rarely, coagulopathies are late complication of long-standing severe cyanosis. There is a platelet dysfunction. On ECG, there is a right axis deviation and right ventricular hypertrophy. By the X-ray, a boot-shaped heart, which is characteristic for TOF, a boot-shaped heart with a concave pulmonary segment. You see here, concave. As always, we say that there is a severe RVOT obstruction. So the pulmonary artery, main pulmonary artery, and branch pulmonary artery usually underdeveloped. Okay, so small. So always there is some degree of concavity in the X-ray. That's in the area of main pulmonary artery segments. Why boot-shaped heart? Because of the RVH, so the apex is pushed lateral and upward, similar to the boot. In addition, right aortic arch is present in 25% of cases with TOFs. The definitive diagnosis is by echo. That's the echo defined the four characteristics of Tetralogy of Value, including the large VSD, including the degree of overriding. That's mean overriding if you have an imaginary line from interventricular septum that's passed through the aorta. Okay, through the aorta. This is overriding, large VSD, and right ventricular hypertrophy. In addition to this is the short axis, show severe RVOT obstruction. Severe RVOT obstruction. The most important feature and characteristic part of the presentation in TOF is hypoxic spell or hypercyanotic spell or Tetralogy spell. It's characterized by a paroxysm of hyperapnea, rapid and deep respiration, irritability and prolonged crying, increasing cyanosis, intense of cyanosis, and decreased intensity of the murmur. Why? Because decreased flow through the RVOT. A severe spell may lead to lameness, convulsion, cerebrovascular accident, or even death. Okay, it's occur in young infants with peak incidence 2 to 4 months of age, and it is less common after 2 years of age. Why? Because after 2 years of age there is development of arterial collaterals from the aorta to the pulmonary artery, so the pulmonary blood flow is maintained by the collaterals. Now, what's the pathophysiology behind hypercyanotic spell or hypoxic spell? Look to this diagram. this is the left ventricle, and this is the right ventricle, and this is the large VSD between the left and right ventricles. This is the outlets of the left ventricle, I mean the aorta, and this is the outlet of the right ventricle, I mean pulmonary artery. So if there is obstruction in the pulmonary artery, so the preference of flow from the RV is to the LV, then to the aorta. So when there is intense obstruction or intense severe stenosis in the RVOT, there will be more volume of blood pumped to the LV and toward the aorta. That means intense cyanosis. This is one. Okay? This point is precipitated by what? By any cause for increased oxygen consumption. Number one. Number two, anxiety, pain, stressful condition, infection. Okay? Other part of the story is if there is decrease in systemic vascular resistance. Example, in case of peripheral vasodilatation. So again, the same mechanism. There is a preference of flow of blood from the RV to the aorta through the VSD, resulting in intense cyanosis. So the mechanism of the or pathophysiology of the hypercyanotic spell is multifactorial. Could include the spasm in the right ventricular outflow tract obstruction, and could be increased oxygen consumption because of crying, because of anxiety, because of pain. Okay, and could be decreased volume, peripheral vasodilatation, dehydration, stressful condition. All these precipitate the state of hypoxic or hypercyanotic spell. So to treat the spell, you need to reverse the mechanism. I mean, increasing the systemic vascular resistance, increase the intravascular volume, decrease oxygen consumption by providing oxygen and relief of pain and anxiety, and try to relieve or decrease the the severity of the RVOT obstruction, decrease the tachycardia, and decrease the or increase the amount of blood that's returned to the RV. Okay, to enhance more blood push to the pulmonary circulation. So medical therapy, the infant should be picked up, I mean hypercyanotic spell, picked up and comforted as soon as episode begin, ideally while being held in a position of a flexed knee and hips that kinks or compresses the femoral arteries and increase the peripheral systemic vascular resistance, which is called knee chase position. Okay, to increase systemic vascular resistance, and that's make the flow preference to the pulmonary circulation. If no improvement is seen within a few minutes, oxygen should be administered and intravenous access should be inserted. Number one, an intravenous bolus of colloid or crystalloid fluid. The aim of a fluid here is to maintain intravascular volume and to increase the venous return to the heart, and that's enhance the increased pulmonary circulation. The second step, administration of intravenous or intramuscular morphine in a dose of 0.1 to 0.2 milligram per kg. This is again for relief of anxiety, relief of pain, and that will decrease the tachycardia, and that will decrease the catecholamine release or catecholaminic changes. If there is no response, then third step, intravenous beta blocker propranolol, 0.015 to 0.02 milligram per kg. Again, this is to decrease catecholaminic surge, to decrease tachycardia, and sometimes relieve some sort of RVOT obstruction. The rule of the tachycardia, that means the diastolic time or diastolic filling time of the RV in the presence of tachycardia is short. So the amount or the volume of blood pushed is little. So one of the important steps is to prolong the diastolic time by decreasing the heart rate. That means there is more blood collected during diastole in the RV and increase the chance of more blood pushed or pumped to the pulmonary circulation. If there is worsening acidosis, so sodium bicarbonate 1 milliequivalent per kg should be given. If no response, then intravenous systemic vasoconstrictor. Again, the same mechanism. If increased systemic vasoconstriction, increased systemic vascular resistance, this will enhance the flow toward the pulmonary circulation. So use of phenylephrine or norepinephrine. If there is no response, even with intravenous vasoconstrictors, patient may need anesthesia, intubation, and ventilation. This to decrease the oxygen consumption and try to terminate the hypercyanotic spells. Very rarely, if there is no response and severe life-threatening spells may require emergency surgical intervention or mechanical circulatory support. This is very rare. Okay. So, tetralogy of Value, as we said, there is 4 components: VSD, RVOT obstruction, and RVH and overriding of aorta. So, what is the treatment? Treatment is surgery. Surgery is divided into 2 steps: either palliative surgery, especially in young infants with recurrent cyanotic spells, small pulmonary arteries, severe cyanosis, degree of cyanosis, that's need palliative procedure to increase pulmonary blood flow in one of the following mechanism: either by using the Platelet or modified Platelet shunt. That's mean in a Platelet shunt, that's mean connection of the subclavian artery to the pulmonary artery. The subclavian artery. If we use the synthetic material, cortex for example, to connect the subclavian artery to the pulmonary artery, it is called modified PT shunt. This is the most commonly used type of shunt, is the PT shunt or modified PT shunt. Previously used Waterstone shunt, which is between the ascending aorta and right pulmonary artery, or Putz shunt between the descending aorta and the left pulmonary artery. The aim is to provide or enhance the pulmonary blood flow from the aorta. This will result in an increase and development and the growth of small pulmonary arteries. This is the main one. The second important is to decrease cyanosis. After that, after doing a PT shunt or modified PT shunt, you need total corrective repair. Okay, this is for patients require palliative. Some of the patients not require palliative, but require the primary total repair, especially if the pulmonary arteries is good in size, or sorry, if the pulmonary arteries are good in SAT. So complete repair, that's mean is closure of the VSD with a patch and relieve obstruction in the RVOT by many mechanisms, transannular patch or transarterial or transpulmonary artery repair. This is not for you. Okay, so you should know that the surgery may be on two steps. The first one is the palliative. The second one is total repair. Usually surgery is done, can be done from the third month of life to 9 months to 1 year of age. The second sign of congenital heart disease is transposition of a great artery. Transposition of a great artery constitutes 5% of all congenital heart disease. It is more common in boys, 3 to 1. Look to the normal heart. This is the right atrium. This is the right ventricle. This is the pulmonary artery. This is the left atrium. This is the left ventricle. This is aorta. So blood from the upper part of the body, SVC, blood from the lower part of the body through the IVC, pass to the right atrium, through the tricuspid valve, pass into the right ventricle, and then pumped to the pulmonary circulation, into the pulmonary artery. In the lung, it is oxygenated, and then return back to the heart through 4 pulmonary veins, 2 left, 2 right, in the left atrium. Oxygenated blood come to the LV through the mitral valve. From the left ventricle, pump to the aorta and then to the systemic circulation. So this is normal circulation. In case of transposition of great arteries, I mean detransposition of great arteries, what's occurred? The aorta is originated from the right ventricle, and the pulmonary artery is originated from the left ventricle. So the blood from the deoxygenated blood from the SVC and from the IVC come to the RA, from the right atrium to the right ventricle, from the right ventricle to the aorta, I mean systemic circulation, and return back to the systemic circulation. And oxygenated blood from the pulmonary vein to the LA, to the LV, from the left ventricle pumped into the pulmonary circulation, to the pulmonary artery, and goes to the lungs, and they return back through the pulmonary vein to the left side of the heart. So separated circulation, pulmonary circulation and systemic circulation. So it is incompatible with life without source of mixing. Okay, so the most important point is that the aorta is connected to the, or originated from the right ventricle and located anteriorly, and pulmonary artery originated from the left ventricle and located posteriorly. Instead of the normal position, the pulmonary artery, which is anteriorly and originated from the RV, and aorta is posteriorly originated from the LV. Okay, this is normal circulation, sequence of normal circulation from the body, RA, RV, PA to the lungs, LA, LV, aorta to the body. In patients with transposition, there is a two parallel circulation, the systemic circulation and the pulmonary circulation. So without some sort of communication, it is incompatible with life. So mixing can occur between the aorta and pulmonary artery through a patent ductus arteriosus, and could be between the right ventricle and left ventricle through the VSD, or could be from the right atrium, between right atrium and left atrium through an ASD. So presence of PDA, ASD, VSD is essential for survival in patients with transposition artery to make some sort for mixing between oxygenated and deoxygenated circulation. Clinical manifestations, cyanosis, and signs of congestive heart failure develop in the newborn period. Severe arterial hypoxemia in response to oxygen inhalation and acidosis are present in neonates with poor mixing. Auscultatory findings are non-specific. The S2 is single and loud. Sometimes no heart murmur is audible in infant with intact ventricular septum. When TGA is associated with VSD or pulmonary stenosis, a systolic murmur of these defects may be audible. So non-specific auscultatory finding in patient with TGA. On ECG, the right axis deviation and right ventricular hypertrophy. On X-ray, cardiomegaly, increased pulmonary vascular markings, a characteristic shape of the heart, which is called egg-shaped cardiac solute with a narrow superior mediastinum. So this is like the egg. Why egg-shaped heart? Because as we said before 2 slides, there is a relation between the aorta and pulmonary. In normal relation, the aorta is posterior and the pulmonary is anterior. In case of TGA, the aorta become anterior and pulmonary turn back to the posterior relation. So the anterior-posterior relationship is different in patients with TGA, resulting in narrow mediastinum. So egg-shaped cardiac solute is characteristic for DTGA. Echo again is diagnostic. You can see in the short axis that the aortic valve, this short axis view, short parasternal axis view, the aorta is anterior and pulmonary is posterior. This is anterior-posterior relationship. In long parasternal view, you will see that the pulmonary artery is originated from the left ventricle, and the pulmonary aortic valve or aorta is originated from the right ventricle. So this is DTGA. Natural history and prognosis depend on the anatomy. So infants with intact ventricular septum are the sickest group, but they demonstrate the most dramatic improvement following prostaglandin E1 infusion or the Rashkin balloon arterial septostomy. Okay, prostaglandin E1 to maintain patency of ductus arteriosus. Okay, so provide a source for mixing. And Rashkin arterial septostomy, I will show you this procedure soon after 1 or 2 slides. Infants with VSD or large PDA are the least cyanotic group. Why? Because there is a source of mixing between circulations. Most likely to develop congestive heart failure and pulmonary vascular obstructive disease as early as 3 to 4 months. Again, as other cyanotic congenital heart disease, cerebrovascular accident, and progressive pulmonary vascular disease, particularly in infants with large VSD and PDA, are rare late complication can occur. Management, medical management, of course, supportive management, metabolic acidosis, hypoglycemia, hypocalcemia should be treated if present. Prostaglandin E1 infusion is started to rise arterial oxygen saturation by reopening or maintain the patency of ductus arteriosus. Administration of oxygen may help rise systemic arterial oxygen saturation little by lowering pulmonary vascular resistance and increase pulmonary blood flow, with resulting increase in mixing. A therapeutic balloon arterial septostomy, Rashkin procedure, may be performed if there is patent foramina ovale or small ASD, less than 5 mm. So during early neonatal period, we induce artificial arterial septal defect by using a balloon through the femoral. Again, we characterize the femoral vein to the IVC, then to the RA through the foramen ovale or small ASD into the RA. Then we will inflate the balloon and then make a tear in the interarterial septum, artificial ASD. This to enhance and magnify the mixing through the interarterial septum. Okay, this is very helpful, and the saturation SpO2 increase significantly and cyanosis decrease significantly. This is give a time for the patient until surgery is taken off, and the patient then may require a balloon if the medical condition of the patient is not suitable for surgery for any reason associated congenital abnormalities, or his medical condition is not fit for surgery, so we do the balloon arterial septostomy until the fitness for surgery. This is Rashkin procedure, very important. It is an emergency procedure. After that, definitive treatment is the surgery. As a definitive surgery, the right and the left sided structure are switched. Okay, so the most important switching, and it is of choice, is the arterial switch operation. That's mean switching this is the aorta and this is the pulmonary artery. Make a switch that make the aorta originate from the alveoli by switching, and the pulmonary originate from the RV. This is arterial switch operation. It is a treatment of choice for patient with DTGA. Other possible switching is at the arterial level. It is called arterial switch operation, not arterial. Arterial mean the artery, switching of the artery, either Sinning or Mustard operation, and at the level of the ventricle using Rastelli operation. Okay, so the most important or procedure of choice in patient with DTGA is arterial switch operation. Okay, now we complete the two parts of the congenital heart disease, which is this cyanotic congenital heart disease, VSD, ASD, and PDA. And cyanotic congenital heart disease, we took only two examples, the Tetralogy of Value and detransposed grade arteries. The third group is the obstructive lesions, including the AS, or aortic stenosis, and pulmonary stenosis, and contractation of aorta. We will discuss them separately in the next year, inshallah. Now we should talk about the congestive heart failure, which is a very important part. It's present in all, can be a sequelae of all congenital heart disease or acquired heart disease. So we need to know what's congestive heart failure, what's the presentation, how to treat, how to diagnose, how to treat congestive heart failure. So congestive heart failure is a clinical syndrome in which the heart is unable to pump enough blood to the body to meet its need to dispose of systemic or pulmonary venous return adequately, or a combination of two. The causes of heart failure is different, multiple. By far, the most common cause of congestive heart failure in infancy are congenital heart disease. Beyond infancy, myocardial dysfunction, for example, myocarditis, for example, dilated cardiomyopathy, tachycardia or tachyarrhythmia, and heart block can also cause heart failure at any age. So, first group of causes of congestive heart failure is congenital heart disease. So, volume overload lesions such as VSD, PDA, atrioventricular septal defect are the most common cause of congestive heart failure in the first 6 months of life. Okay, in the PDA we said the PDA patient can present with congestive heart failure. And the ASD, rarely it can present with ASD, with heart failure. VSD, we said that it can present with heart. So the most common lesion, volume overload lesions, can present in the first 6 months with congestive heart failure. Large left to right shunt lesions such as VSD, PDA do not cause heart failure before 6 to 8 weeks. And we discussed that's why in the last lecture, because increased pulmonary vascular resistance, so the amount of shunt is somewhat little. Until 6 to 8 weeks, the PVR decrease, pulmonary vascular resistance decrease, so gradient is increased, so more blood shunted from the LV to the RV. Okay, so large lesions, large shunt. In this table, an example, just to look to this, have a look to this table that show causes of congestive heart failure resulting from congenital heart disease. This is just for interest, not required from you. At birth, for example, hypoplastic heart syndrome can present with heart failure. In the first week, for example, PDA, TGA, total anomalous can present with, and so on. In the first month, correctation of aorta, critical AS, in addition to ASD, VSD, in premature. After 6 weeks, large VSD, large PDA, and so on. So the first group of causes of congestive heart failure is congenital heart disease. The second group is acquired heart disease. That include viral myocarditis, myocarditis associated with Kawasaki disease, acute rheumatic carditis, rheumatic valvular heart disease, dilated cardiomyopathy, doxorubicin cardiomyopathy, cardiotoxicity associated with chemotherapy, and cardiomyopathies associated with muscular dystrophy and Friedreich ataxia. Okay, all these are acquired causes for heart failure. Miscellaneous causes including metabolic abnormalities, for example, severe hypoxia, acidosis, hypoglycemia, yes, hypoglycemia, and hypocalcemia, especially in premature, especially in newborn, newborn. Hyperthyroidism at any age can cause heart failure. Arrhythmia, including supraventricular tachycardia, complete heart block. Severe anemia, yeah, can cause heart failure. Primary carnitine deficiency, acute cor pulmonale, that means right side heart failure or pulmonary cause causing heart failure. And acute systemic hypertension with glomerulonephritis can cause congestive heart failure. So, heart failure presented with poor feeding of recent onset, tachypnea, poor weight gain, cold sweat on the forehead, suggestive congestive heart failure in infants. In older children, shortness of breath, especially with activities, easy fatigability, puffy eyelids, or swollen feet may be presenting complex. Physical finding can be divided by pathophysiologic subgroups. A. Compensatory responses to impaired cardiac function. So the patients come with tachycardia, low rhythm, weak 3D pulses, cardiomegaly, on-chest X-ray, sign of increased sympathetic discharge, growth failure, sweating, cold wet skin. This is the first subgroup. The second is signs of pulmonary venous congestion, including tachypnea, dyspnea on exertion, and poor feeding in small infants. In older children and adolescents, orthopnea, and rarely wheezing, cardiac asthma, and pulmonary crackle, called cardiac asthma. The third group is sign of systemic venous congestion, right side failure, including hepatomegaly, ascites, distended neck, puffiness, leg edema, and so on. Although the leg edema, puffiness is not seen in infants, but hepatomegaly can be seen. So, compensatory responses, pulmonary venous congestion, left-sided failure, and systemic venous congestion, right-sided failure. By X-ray, there is cardiomegaly, and the cardiomegaly depends on the severity of the congestive heart failure and due to enlargement of the cardiac chamber. The ECG is not helpful to decide this is in failure or not in failure, but it can give an indication for the possible underlying cause. For example, in case of arrhythmia, so give you hint in case of myocarditis, okay, in case of ischemia, so can suggest the underlying cause, but not define this patient in failure or not in failure. Again, echo study confirmed the presence of chamber enlargement, impaired LV function, any hemodynamic sequelae and complication of congestive heart failure and severe LV dysfunction, for example, a thrombus, valvular lesion, structural lesion, okay? So the echo is important in the diagnosis of congestive heart failure and assessment of heart failure. Also, plasma natriuretic peptide, arterial natriuretic peptide and beta natriuretic peptide are helpful in the diagnosis and in the follow-up and response to a treatment. So how we can manage a patient with congenital heart disease? First, elimination of the underlying cause or correction of precipitating or contributing causes. For example, patient with infection, anemia, arrhythmia, fever, hypertension, so treatment of the underlying cause. Second is supportive measures, including bed rest, according to the severity of the failure and LV dysfunction. Nutritional support, okay, very important nutritional support, especially in those young infants with heart failure and poor feeding. So part of the important part of the treatment is the nutritional support. Third is control of heart failure state by using of medication. Example, inotropic agent, diuretics, afterload reducing agent, beta blockers, digoxin, and so on. So the first group is diuretics. Diuretics remain the principal therapeutic agent to control pulmonary and systemic venous congestion. So it's decrease the preload on the heart and improve congestive symptom. Three group, as you know, of diuretic use in congestive heart failure, including thiazide diuretics, loop diuretics, and aldosterone antagonists. The most important two is Frozamide. The dose is 1 mg per kg per dose IV, and 2 to 3 mg per kg per day in 2 to 3 doses orally. The other important one is the Aldactone, orally 1 to 3 mg per kg per day in 2 to 3 divided doses. The other group of drugs used in the congestive heart failure is the rapidly acting inotropic agent. In critically ill infants with congestive heart failure, rapidly acting catecholamines with a short duration of action are preferable. Example is epinephrine and isoproterenol, dobutamine and dopamine. Dobutamine 2 to 8 microgram per kg per minute IV infusion, that can cause tachycardia, vasodilatation and arrhythmia. Dopamine, the dose of dopamine, cardiac dose of dopamine 5 to 10 microgram per kg per minute IV. Also the same, can cause tachycardia, arrhythmias, hypotension, hypertension. Okay, it can give the dopamine according to the dose used. It have if we use in 2 to 5 mic per kg per minute, this is a renal vasodilator, so renal dose of dopamine. Inotropic, increased contractility, if we use it in 5 to 8 mic per kg per minute. More than 8 is causing tachycardia, chronotropic effect. Vasoconstriction is more than 10, especially 15 to 20 mic per kg is vasoconstrictive effect of dopamine. The other group is after load reducing agent, reducing afterload, tends to augment the stroke volume without a great change in the inotropic state of the heart, and therefore without increasing oxygen consumption by the myocardial cells. So combined use of inotropic agent, vasodilator, diuretic produce most improvement in the both inotropic state and congestive symptoms. Examples for vasodilator, including the arteriolar vasodilator like hydralazine, or venodilator, including nitroglycerin, and mixed vasodilator, which is the most important, is the ACE inhibitor, including captopril and enalapril, which is very important and cornerstone treatment in the heart failure to decrease, of course, the afterload and the preload and improve morbidity and mortality. It is important to know that there is an important possible side effect of the ACE inhibitor is the hypotension. So take care of the first dose hypotension when you use ACE inhibitors. Other drug is the digoxin, act by inhibition of sodium-potassium ATPase, mainly in the myocardium, lead to increases in the cardiac output, increased contractility. This is very important. That's use of digoxin in infant with large left to right shunt, for example, large PDA, large VSD, is controversial because ventricular contractility is normal in this situation. So the main mechanism of action in digoxin is increasing contractility. So in patient with VSD, the contractility is preserved. In patient with PDA, the contractility is preserved. So it is not wise to use unless some improvement can occur due to parasympathomimetic effects of the digoxin. So usually we not use or not recommend use of digoxin in treatment of heart failure in VSD or PDA. Yes, it can be used significant and cause significant improvement in patient with dilated cardiomyopathy because the contractility is decreased. The dose of digoxin is differ from according to the age group. In a premature, the total digitalizing dose is 20 mic, while the maintenance is 5. In a newborn, 30, while the maintenance is 8. Less than 2 year, 40 to 50, while the maintenance 10 to 12. After 2 year, 30 to 40, and the maintenance is 8 to 10. To start digitalization, there is a total digitalizing dose measured according to the body weight and divided into 50% of the dose is given in the 0 time, okay, given IV. After 6 to 8 hours, up to 12 hours, give the second dose, which is 25% of the total dose, and the third dose, which is also 25% of the total dose, given after 6 to 8 hours of the second dose. For example, a patient, the total digitalization dose is 100 mic. So 100 mic, 50%, 50 mic can be given during this the first dose during 0 time. And after 6 to 8 hours, up to 12 hours, give the second dose, which is 25% of the total. So give 25 mic IV. After the second dose, we give the third dose, also 25% of the total dose, given IV after 6 to 8, and some prefer after 12 hours. So the total dose of digitalizing divided into half or 50%, 1/4, and 1/4, and given in 3 doses. The beta-adrenergic blocker or beta blocker have been shown to be beneficial in patients with chronic congestive heart failure. So chronic, This is important, not acute. Who were treated with the standard anticongestive drug to overcome the adrenergic overstimulation may have detrimental effect on the failing heart. I mean in the acute heart failure, because it's induced myocardial injury and necrosis. So beta blocker is used in chronic congestive heart failure. It's shown to that improve the mortality and morbidity in patients with chronic congestive heart failure. Example, carvedilol, metoprolol, and bisoprolol. Thank you for listening, and you can email me for any question or discussion. I hope it's helpful for you, and thank you.